Thank you so much. First of all, I want to thank ESI team and my close friend Dr. Ram Mohan for this wonderful opportunity to talk about primary ovarian insufficiency and HRT in that particular setup. Now, if you have listened to Suresh sir's talk, this is going to be mostly a rehash, a little bit of reinforcement here and there about HRT in this particular setting. So, what is primary ovarian insufficiency? We need to have three things to call a patient as having POI. The patient should be less than 40 years of age. Why 40? That's an arbitrary number. Normally, women tend to have menopause at somewhere around 50, depend, give or take a few years. And anybody who develops stopping of menses before 40 years is arbitrarily considered to have premature or primary ovarian insufficiency. They must have amenorrhea for a minimum of 4 months, although a rock solid diagnosis would require 6 months, and menopausal FSH level. That means the FSH level has to be high. Subsequent slides I'll show you how high it should be. And important thing is it has to be done twice, and those two readings have to be taken at least a month apart. So these are some things we should satisfy before labeling a patient as POI. Now, why do we harp on these diagnostic criteria? Is because POI is a life-altering diagnosis to any woman. The sudden and unexpected possibility of infertility as well as cessation of menses can be harrowing to any woman, especially in a conservative country where femininity is tied with the ability to have a child or to have menses, which is why we need to be very careful in labeling a patient as POI. Now, the first question is it just an early menopause? Many people will think that my mother or first cousin had a menopause at somewhere around 42. Is it just an early thing? The way it differs from early menopause is that there is an unpredictable resumption of ovarian activity in patients with POI, which is not there with menopause. And therefore, this represents a possible fertility potential both for women desirous of fertility and those who don't want fertility. This spontaneous and unpredictable resumption in ovarian activity is important, and we need to tackle this in a separate way. Now, the next question comes: should I wait for typical 6 months of amenorrhea to label a person or as POI, or can we start evaluation earlier? Now, typically, this progress through normal to overt POI is faster than with the normal perimenopausal period. However, many of these patients would be in a stage of occult or biochemical POI where their menses may be regular, but the fertility is reduced and their serum FSH is elevated, which is why the trigger for evaluation should start with at least 3 months of amenorrhea or perhaps 4 months of amenorrhea. Now, we have looked at the ways and means when we trigger the evaluation of a patient with POI. We have to strike a balance between overdiagnosis and delayed diagnosis. So, we overdiagnosis risk is there if we fail to exclude other causes, including pregnancy in these patients. Delayed diagnosis is a problem if we wait for 6 months to 8 months of amenorrhea instead of starting it at 3 months. And these things can be basically told as disturbed menses with a menopausal level of FSH. That's when we think of a POI. So, what are the FSH cutoffs? There are various cutoffs. UK NICE gives 30 IU per liter. ESHRE is 25, and the Volt cutoff is 40. So, the idea is different cutoffs work to catch different kinds of patients. 25 cutoff is used because patients with autoimmune POI tend, especially the steroid cell autoimmunity POI, tend to have a lower FSH than other patients, and therefore, if we want to catch more patients, then we may have to use a lower cutoff, with the caveat that we may pick up some false positives, and that is why we need to have the second FSH which shows consistent elevation, which will reduce the risk of false positive. How common is this condition? Depending on the age group, this can be seen in up to 1% of patients under 40 years. And with each decade after 20 years, the prevalence rises tenfold, even though the numbers are just 0.01 to 0.121%. What are the clinical features? The preeminent clinical feature is amenorrhea. Usually it's a secondary amenorrhea. Occasionally it can even be primary amenorrhea. Systemic features such as hot flushes and mood changes and quite a bit of non-specific features can be there, just like menopause that occurs on time. This is a premature kind of menopause. And syndromic features can be present, especially in patients who have primary amenorrhea, and POI that presents as primary amenorrhea may be associated with a variety of syndromes. Now, how does it happen? There are broadly two ways in which this POI occurs. One is that the follicle can dysfunction. Second is that the follicles may be depleted. The patient might think, uh, was I born with less number of follicles so that I was doomed to have a POI? It is very hard to prove follicle depletion, because even if the ovarian biopsy, which is not recommended for this condition, even if the biopsy doesn't show any follicles, there have been reports of women getting pregnant after that. So follicle depletion is hard to prove. In most cases, it is usually follicle dysfunction. Now, when we think of follicle dysfunction, it could be because of a signaling defect like LH receptor or FSH receptor or G protein abnormalities, or enzyme defects like 7020 lyase or aromatase defects, autoimmunity, a huge chunk of patients, and then women born with insufficient follicular number. The other group is the follicle depletion group, where patients have inherited follicle depletion, where they're born with low number, or there is an accelerated loss of follicle. The other group, of course, is acquired, meaning environmental toxins. These are relatively rare causes. So if we see the overall landscape of how this occurs, we can see that autoimmunity probably accounts for a good number of cases, even though it may not be proved. So one of the important things to remember is that unlike testis, which is relatively immunologically privileged, the ovary isn't immunologically privileged. Therefore, it is exposed to autoimmune attack, and that is why this is more common in women rather than men. We don't have autoimmune orchitis as commonly as autoimmune otitis. Now, one might wonder, why should we know all of these things if we are anyway going to give standard estrogen and progesterone hormone replacement? The reason for that is POI management is more than just the right amount of hormone. The exact cause will help us in treating the systemic problems of the patient, as well as counseling her as to further risks in terms of cardiovascular risk and also genetic counseling. So the right diagnosis matters, even though we may end up giving estrogen progesterone to many of these patients. So diagnosis requires a careful personal and family history. Family history is extremely important in these women, not only because this condition can be inherited either as a polygenic trait or sometimes very rarely as single genes, but also because the patient's perception of what is the normal time of menopause is closely correlated with what her peers and her mother and sisters have gone through. So this may uh, have a situation where a woman is not greatly interested in hormone replacement therapy because her mother was not given that and she seemed to be doing fine. So which is important for us to take the family history. Amenorrhea may be intermittent or permanent and may occur before menarche, as we discussed earlier. The question is, should I do a test, or can I just give some progesterone withdrawal and see if a patient passes that? Can we label her as normal? The answer is no. 50% of women with POI can have withdrawal bleeding with progesterone, and therefore the withdrawal bleeding does not rule out the possibility of POI. So we need to test these patients. There are two kinds of tests we can do. One, to confirm the diagnosis, and the second kind of tests to identify why the patient developed POI in the first place. For confirmatory tests, we have FSH done on two occasions, 4 to 6 weeks apart. If the patient has intermittent menstruation, it would be best to do on day 3 of the cycle or day 2 of the cycle, so that the estradiol levels don't feedback to have a slightly lowish FSH. AMH is not necessary for the diagnosis. Occasionally, it can be done if facilities are available, but it is not recommended for the diagnosis. The next group of tests is to find out why exactly the patient developed a premature ovarian insufficiency. Now, proceeding further depends on what kind of resources the patient and we as doctors have access to. About 5% are genetic disorders, 10% are autoimmune diseases, familial recurrences in 20%, and vast majority of causes are idiopathic. It remains a mystery even after repeated testing. So how much we invest in diagnosis will depend on what kind of patients we have access to. These are the common recommended tests. The genetic screening include karyotype and fragile X pre-mutation testing. Adrenal cortex and 21 hydroxylase antibodies need to be tested. This test is of course not very commonly available and quite expensive. Depending on the situation, we need to customize this list to our working conditions. Thyroid in full TFT and thyroid peroxidase antibodies may be needed. Ultrasound to assess ovarian presence, size, antral follicle count, and pathology. Apart from that, we can do toxic screen or metabolic screen or infectious screen or screening for iatrogenic causes. All of these will depend on the given patient's history. But all of the patients should get those investigations which are given in bold here. Most patients should get these investigations which are given in bold. The others, like infectious screening or metabolic screening, are dictated by the current clinical scenario. What does a positive test mean and what does a negative test mean? So it depends on what kind of test we do. If the fragile X mutation testing is positive, then we refer to a geneticist. If 21 hydroxylase antibodies are positive, then the patient needs to be referred to an endocrinologist. Karyotyping, if it is positive, if there is a Y chromosomal material, then the patient may need to discuss the possibility of gonadectomy. So not only these tests, each and every test we should have an understanding of what a positive test means and what a negative test means to the patient in the context of POI. So before we proceed further, let's start with some vignette. It's a 37-year-old female, secondary amenorrhea for the last 6 months. She has hot flushes. Her mother had menopause at 40 years. She wonders if she should take hormones. The only problem is she has gone through the internet and she finds some conflicting information that hormones can be dangerous and they are associated with all kinds of serious things. And she's a little bit confused what to do with the hormones. Now, the process with which we proceed with the patient is to get a proper diagnosis. Then the crucial step is to counsel the patient as to what we are trying to do and what we are trying to achieve so that the patient makes an informed decision, a shared informed decision on hormone therapy. Then we institute the hormone replacement therapy and then we follow up the patient. This is the process we follow for these patients. Now, the patient would like to know what hormone replacement therapy is. The term itself has come into a little bit of disrepute after the WHO study, but the patient needs to understand that it's simply replacing what the body is not able to produce. The ovary produces these hormones, estrogen, progesterone, and testosterone. And basically, hormone replacement therapy typically means we replace two of these three hormones, which is estrogen and progesterone. Testosterone replacement is a complicated thing. For most patients, that's not recommended. Then the patient might wonder, is this HRT the same as some 50-year-old lady takes, or is it any different from a menopausal HRT? There are three important differences. One is the need to take a HRT in a normal woman who reaches menopause at normal time. We may not be very pushy about hormone replacement therapy, although we need to be. In this case, we need to be quite pushy about hormone replacement therapy because the benefits are huge and the risks are also huge if the patient refuses it. So the risk benefit ratio differs. And in some situations where the woman is desirous of fertility, even the goals of the therapy are different. Because of these things, we need to have some kind of a toolkit to understand. I know the word is a little bit controversial, but for the sake of discussion, a toolkit means that we have a set of ideas and set of concepts which we can tell the patient to enable her to take a decision on hormone replacement therapy. So what is the decision matrix we need to ask? Every intervention that we give to a woman has to satisfy all four of these things. We need to make her think through these things. One is the benefits of the treatment, what she stands to gain by the treatment. Second is the risks of treatment. Third, are there any alternatives that are less risky or more beneficial? And finally, what will happen if there is no treatment given to the patient? So that if she is able to slot into each of these four boxes, she will be able to take a better decision. Now, when we are looking at benefits and risks, one of the most important problems we face is the loss aversion bias. This is well documented in many situations. The loss aversion bias means that the pain from the loss is often higher than the pleasure from gain. So, losing 10 rupees feels worse than gaining 50 rupees. That's the kind of loss aversion bias that we're all born with. And that results in a kind of policy paralysis. So people might say, instead of risking anything new, let's just play it safe until we slowly decline into obsolescence. So this loss aversion bias has to be countered with proper communication. Now, this is the woman who is a little bit concerned about uh, any problems to the cardiovascular system or to the risk of breast in terms of breast cancer. So when we look at problems to the cardiovascular system, we have to tell the patient that whatever things that she sees in the internet have something to do with older women who are taking hormone replacement therapy, and it cannot be directly extrapolated to studies for primary ovarian insufficiency. Keeps and elite studies have shown that this HRT in the setting of POA is safe for the heart, not only because the therapy itself is safe, but also because the woman itself is at a much lower risk because of the young age. So there is very little risk, absolute risk, to majority of the women who take hormone replacement therapy in POI. This is especially true in Indian setup, where women are at least uh, till now very less likely to be chronic smokers or chronic alcoholics. Coming to the second question that she might have, is there an increased risk of breast cancer? Then again, we cannot extrapolate from studies done for older women. Even in the studies done for older women, if we look at this graphic, what we can see is that for 1,000 women who had started on HRT for 5 years at the age of 50, and we follow them up till 70 years, about 8 women develop extra breast cancer over a period of 20 years. You know, 8 women out of 1,000. That is the very low risk of HRT, even if it is started at 50 years. For young women who are started with HRT, there is no known risk of breast carcinoma, and this should be emphasized to the patient that she is quite clear on this. Final question would be, is there a risk of blood clots? Thrombosis risk is often overrated. People often confuse that thrombosis risk that occurs with oral contraceptive pills, which contain a higher estrogen content, is not the same as thrombosis risk with hormone replacement therapy. So these should not be equated. And even in those patients who are taking oral contraceptive pills for contraception, the risk is grossly overrated. This is the British body which in 1995 told the unsuspecting British public that the third generation OCPs doubled the risk of venous clots. And it showed that the relative risk increase is about 100%. That's double the risk. When they looked into the data, they found that the absolute risk was simply one additional case of venous thrombosis in 7,000 treated women. So previously it was one, now it became two. Because of this poor messaging, nearly 13,000 abortions took place in the next year, and the and the UK government had to lose about 4 billion pounds. So we need to be very careful about how we message this. The messaging should be consistent, clear, and simple. The HRT is very safe for vast majority of women who are treated with this. So after your counseling, the patient is now ready for HRT. Do we just jump in and give some hormones? No. We need to ensure that the patient understands HRT is one of the treatments which is given in the overall holistic manner, where we try to reduce the cardiovascular risk as well as the bone risk. This includes a balanced diet, weight maintenance, and weight bearing exercise, adequate calcium and vitamin D intake, avoidance of smoking, and limitation of alcohol intake. All of these have to be instituted in parallel along with HRT for us to have the optimal outcomes. And then we do some baseline tests. Again, the baseline tests depend on where we work and what kind of things we have access to, but these are there for most of our patients. Height, weight, BMI, blood pressure, very important to check. LFT, liver function test, kidney function test, a diabetes screen, a bone screen with the DEXA scan. If it is normal, it needs to be repeated after 2 years. A lipid panel and CVD risk estimation with whatever risk engine is validated in that population, and mammography and cervical cancer screening as per the national guidelines. So all of them have to be done before we institute hormone replacement therapy. Now that brings us to how do we replace the hormones? We have to replace two hormones, estrogens and progesterone. We can, this again has been dealt with excellently by Suresh sir. So we can have transdermal replacement or oral replacement. In our country, most often oral replacement is given. In oral replacement, again, this is the dose equivalent for converting between one kind of estrogen to other kind of estrogen. And progesterone can be given as bioidentical natural progesterone or one of the synthetic progesterones. So the idea is to give estrogen and progesterone together. This is not as progesterone daily as is given for contraception, but the difference is that progesterone is given for only a short period in every month. That is day 1 to day 12 of every calendar month. The patient takes estrogen daily. Now, is there anything to choose between the different kind of preparations, estrogen and progesterone preparation? Transdermal preparations are the best because they don't pose any thrombosis risk, whereas anything oral has a slight thrombotic risk. And estradiol is better than conjugated equine estrogen. In a recently done meta-analysis, they found that conjugated estrogen plus medroxyprogesterone acetate has the highest risk of thrombosis, whereas estradiol plus dydrogesterone has the lowest risk. Coming to the kind of progesterone to choose, micronized progesterone versus MPA, there is no difference in thrombosis risk. If we look at the overall evidence, micronized progesterone may be slightly better for CV and breast cancer risk. At the same time, it may be slightly inferior for endometrial protection. So between these two things, it depends on availability, and it's a close call. But micronized progesterone may have a slight edge over medroxyprogesterone acetate. In the same way, estradiol valeric may have a slight edge over CE. Route of administration matters. Bypassing the liver is better because it has less probability of inducing the production of clotting factors and all that. And local administration may be better. This is the comparison chart. You can get it from BMJ 2019 paper, which tells you what is the risk of combining different kinds of estrogens in various permutations and combinations. So what we are routinely doing is the estradiol valeric plus uh, micronized progesterone or medroxyprogesterone acetate in some cases. The focus of this talk is on hormone replacement. Fertility may be decided by some women. The idea of this slide is not to give a detailed account of what can be done for fertility. The idea is to show that fertility is possible in these women. It's not a dead end, and that oocyte donation and other methods are there for fertility preservation in many of these women. So that brings us to the follow-up. In follow-up, we need to see these 5 things: the quality of life, which would depend on shared decision making and the way in which we communicate to the patient. The patient should have a personalized management plan. Second and often neglected thing is the mental health. We need to be on the lookout for depression because many of these women feel a little less feminine and inadequate, and they need to be counseled and given adequate emotional support. Sexual health in patients with very low libido in spite of replacement, there may be a indication for androgen therapy, but then again it's fraught with complications and most women tend to basically say no. And vulvovaginal atrophy or symptoms can be treated with even local estrogens. And finally, cardiovascular and bone health are the systemic reasons for which we treat these patients. Risk assessment and multifactorial risk intervention are indicated for these patients, just like any other cardiovascular risk reduction. And bone health, we need to ensure adequate calcium and vitamin D intake. And if osteoporosis is found, then to try and delay bisphosphonates if the patient is desiring pregnancy, and even otherwise to delay bisphosphonates as much as possible and treat with other available medications that we have. So that's how we follow up these patients. Is there a role for androgen? Uh, there is a possible role, but the thing is controversial as to what androgen to give. Is it okay to give a mild thing like DHEA or industrial strength testosterone? How much and all that is a little bit controversial, but most people anyway say no to it. Genetic counseling: women with POI with abnormal karyotype and those with the FMR1 pre-mutation should be offered genetic counseling. This means not just us doing it, but to referring to a proper genetics expert. Should the relatives be tested? Relatives with FMR, I mean, if a woman has FMR1 pre-mutation, then they can be offered genetic counseling. Unfortunately, there are no predictive tests to identify POI, and no methods are there to prevent POI. So the value of testing of relatives is highly questionable. That brings us to the last part, POI in teens. We need to understand that menstruation is a vital sign. There is often a unfortunate attitude that when in the initial few months or years of I mean, after menarche anything goes, that idea is not supported by data. Even in such irregular period time, when irregular periods are normal, more than 90 days amenorrhea is abnormal, and that deserves evaluation. These group of patients have a higher likelihood of having some syndromic or genetic causes, and we need to have a family systems approach. What do I mean by a family systems approach? It means involving the parents in the decision making process. And these are the usual talking points we discuss with the parents. What does this POI mean? Why it happens? What it means to the woman's health? What she should tell her friends? Will she be able to have children? And what can she do about it? These are the things that we discuss with the parents. And ultimately, we basically listen with the third ear, in the sense that we look at non-verbal clues and understand what exactly their concerns are. Sometimes they may not be comfortable to voice those concerns. With enough experience, we will learn to understand what exactly are they feeling and try to address that proactively. Induction of puberty again has been covered in the previous talks. Basically, we start at around 11 to 12 years. We try and mimic normal puberty. We give low dose estrogen for about 1.5 to 2 years, and then continue with the progesterone supplementation once the bleeding occurs, or at least 2 years of estrogen therapy is over. So these are the different doses and the different formulations which can be given in patients depending on the age of onset of induction. Again, this has been previously covered, so I will not be going into the micro details of these things. So some of the things to note are spontaneous pregnancy is possible in 5 to 10% of patients, and therefore patients should be using contraception, either barrier or IUDs, and maintaining menstrual calendar and checking for a pregnancy if there are missed periods is important, especially in sexually active teens. So to summarize this talk, the diagnosis depends on confirming that the patient indeed has POI, and then to look for etiology of POI, with the caveat that many cases we may not be able to come to an etiological diagnosis. Communication is a key aspect of this management because this can be a life-altering diagnosis, a heavy psychological blow to many women, and therefore the blow has to be softened with adequate communication. absolute risk of hormone replacement is very low for majority of women, and most women should be encouraged to take hormone replacement. We can choose the estrogen and progesterone for maximum benefit with least risk and acceptable costs. And this has to be continued till the time of normal menopause, around 50 years. And the holistic management includes looking at the cardiovascular risk and reducing it, and the bone risk, as well as sexual problems and their psychological problems. So it's not just replacing the hormones, but treating the patient as a whole. So with that, I conclude my talk. Thank you so much for listening. I once again thank the organizers for the wonderful opportunity.